Good morning, good afternoon, good evening, and good night, friends and colleagues from across the world. Welcome to our second Podinar session of the day with a special guest, Dr. Jeffrey Hoos. Thank you for joining us.
Oh, you're so welcome. I'm excited to be here.
Yes, I was looking very much forward to the Podinar with you, considering all that I've seen over the years from your accolades and training and educating other doctors and the things that you post. Very impressive. Dr. Hoos, if I may, I'm going to introduce you very briefly to our audience. Dr. Jeffrey Hoos, DMD, is a highly trained and educated dental practitioner who's very regarded in the dental professional circles nationally and worldwide. Personally, I have followed him over a decade. Dr. Hoos graduated from the Tufts University School of Dental Medicine after earning his DMD degree. He's also a graduate of the University of Bridgeport in Connecticut and Drew University in New Jersey, where he earned an MS in biology and a BA in zoology, respectively. Dr. Jeffrey Hoos is a fellow of the Academy of General Dentistry, a fellow of the Academy of Implant Dentistry as well. In recognition of his dedication to clinical excellence, Dr. Hoos has earned a prestigious Brennemark certification in surgical placement and restoration of dental implants. Dr. Hoos has also been honored by the Society of Dental and Facial Aesthetics, and he's also a recipient of the Block Drug Award for his contribution of teaching proper oral hygiene to the developmentally disabled. Wow, you've been at it for over 40 years, Doc, have you not?
Yeah, you see this? That's all a result.
Yeah, well, it's good what you have done for our profession. We're very, very appreciative of that. So you got a DMD back in the early days when they started giving out DMDs, huh?
Yeah, so what happened in the United States was that the concept of having some medicine within your education, they thought the degree was a bit more prestigious. I have to tell you, it's all lies. It's all lies. We're all highly trained, and so having a DDS or a DMD. But my mother-in-law will quickly tell you that I'm not really a doctor, so don't worry.
Yes, I agree with you. I got a DMD too, but it was long after you. We're all dentists at the end of the day, and we're all colleagues. But I'm very impressed because you've seen a lot of people come and go. Did you meet Brennemark?
So I was actually fortunate enough to have a lunch with him, and I was in the group with the first 30 doctors to be trained as a general dentist to place straight wall external hex implants. And I was fortunate enough to be trained with a Dr. Schnittman in Boston, who was one of the first people in the United States to place straight wall implants. And what was interesting is when
what do you mean straight wall? Like press fit, or are you talking?
No, these are parallel wall titanium external hex implants.
External hex. Will you get good retention?
Absolutely. The concept was that the story is very clear that Brennemark, when he discovered titanium implantology, because he had borrowed some pieces from a friend of his who was a watchmaker, and he was doing studies on rabbits with glass slides. And when he went to unscrew the titanium pieces, they broke off in the bone. And the light bulb went off. What happened? Why would these break in the bone? And so it's that light bulb moment that started him on his quest to figure out what was happening with osseointegration. His concept was not to do teeth in the beginning. And so it's a great story. And his design factors in terms of straight wall, no surface coating, external hex. And then, of course, through the years, I mean, there were only 125 implant companies creating implants at this point. And of course, and like all things get better and things change. And so we know that having an internal Morse taper with a connection is better than, an external hex. But at the same token, when we have multi units, it is nearly impossible to get prostheses that are passive and screw down in terms of an internal Morse taper design. But that's another story.
No, I mean, it's an interesting discussion. A lot of our viewership are all surgeons, general dentists practicing in implantology and other surgical disciplines. So it's an interesting concept. So do you think we have the magic bullet now with the conical hex, or do you think we can expect more innovation in this space?
Well, I think that we can expect more innovation. As you may know, that Nobel has come up with another connection that's been introduced in Italy, and in Europe it's not introduced in the United States yet. But one of the things that I've learned the hard way, occlusion, comma, occlusion, and guess what? It's all about occlusion. I have this theory that is totally unproven, and I say in some of my lectures, the only time people lose teeth is when we doctors take them out. And, you know, it's amazing. You'll see patients that, and in your 40th year of private practice, you'll see patients that you've treated for 40 years and you've told them 30 years ago they were going to lose this tooth, and somehow it seems to keep hanging around. I think that when we create this third set of teeth for people, a phrase that I learned from Joel Rosenlick, actually, that third set of teeth, it is fascinating how when we first started doing hybrid dentures with acrylic teeth, how these patients wore them down. They were destroying those also. How did they do that? For me, it's management of parafunctional habits. When you have, and I will say that when you have cases that you've done that are porcelain fused to metal, that are implant supported, and you see the porcelain breaking, why is the porcelain breaking? Porcelain's breaking from occlusal forces. And I have some concerns that even with full arch zirconia cases, we are seeing wear and breakage on these cases. It is really the management of occlusion. It's the management of parafunctional habits in the evening or at night. So I treat a lot of TMD patients, a tremendous number of TMD patients. And for me, you can give someone the most beautiful, perfect occlusion in the world with anterior disclusion and no balancing side contacts. And the truth of the matter is they still destroy things. So I am a great—
What is your policy? I mean, some doctors promote in the wear and dentition scenario that you address the anterior guidance first before you
absolutely.
So that's your position as well.
And that's my position. And I'm also a great believer in point stop appliances. I'm a disciple of Jim Boyd. And if you have an opportunity to have Jim Boyd on one of these podcasts, it'd be wonderful. I will tell you that management of muscle management for me is the key. And having been at this game a long time, I mean, I trained with Gelb and I got to meet Tanner and, you know, and did neuromuscular dentistry for a while and, you know, and had been through lots of different disciplines. And I'm convinced that it's an eclectic approach. There's not one bullet. There's not one, you know, one occlusal scheme that fits everybody. I'll tell you I'll ask you an interesting question. Can you tell me one thing that everyone agrees upon in occlusion? Can you come up with one? So let's talk about it.
Let me think.
Do you think that anterior guidance is critical?
I think it's critical, but what I'm trying to figure out for, especially probably a lot of our audience has the same question. You learned how to manage anterior guidance in your natural dentition, but when you're talking about zirconia, full arch cases breaking, how would you teach our colleagues to do it on prosthetics to get the proper guidance?
Well, here's the interesting thing. In dentures, you would never give someone anterior guidance.
Right, yeah, posterior.
But more importantly, if you talk to people who are neuromuscularly committed and the mandible comes down and forward, lots of those patients don't have anterior guidance. And so they still—
What is the way of properly So that's what I was talking about at the beginning about anterior guidance, is that your position. For full arch prosthetics or other kind of prosthesis, how do we prevent them from breaking, short of putting metal bars in there and all of that good stuff?
So no one ever breaks anything. No one breaks, no, for me, no one ever breaks anything when it comes to their daily function. Patients only break things at night.
Night, and they're grinding, sure.
And they grind. And so therefore, for all of my prosthetic cases, all of them, full mouth recon, 30 units, 15 units, whatever it is, they all get an anterior point stop appliance for wear at night for muscle management. Now, there are lots of people who will tell you, and they're a whole lot smarter than I am. They will tell you, if you design your case properly, you don't need to do that. Okay? In my hands, I love that expression, in my hands, when somebody has spent thousands of dollars,
tens of thousands sometimes,
of dollars, and their case goes in the mouth, what makes you think for a moment that you're going to be able to do something better than nature? What makes you think for a moment that you can design something better than nature? Patients come in, you must understand why they lost their teeth. You have to understand why they lost their teeth. Well, a dentist took out my teeth. Okay. I lost it due to the fact I ate too much sugar. Okay. But the truth of the matter is we see hundreds and hundreds of patients where their teeth are in terrible condition, but they still have them.
Right.
It's just a word. It's just a word from a wise, from an older dentist to say to a younger dentist, when you start looking at your cases that are 15, 20, 25 years old, and someone turns to you and they say, you know, Dr. Hoos, I know you did all these crowns, gold onlays, porcelain fused to metal, gold backs, however you did it, and why did my tooth on my upper right bicuspid break? Or why did it split? What's your responsibility to that patient? And you can say, you can be flip and say, how long did your last car last? Well, the truth of the matter is, maybe it only lasted 10 years, but I paid you thousands of dollars and this tooth broke. What are you going to do for me? Well, we're going to take the root out. We're going to place an implant. How much is that going to cost me? So remember, John Coy says, the best dentistry is no dentistry. When you have a 16-year-old kid come into your practice with an occlusal on tooth number 19 or lower left first molar, the moment you put a drill on that tooth, you've set that tooth up for a whole lot of dentistry. And that's just the way.
You're not a big fan of preventative, like PRRs and opening up the grooves and stuff like that?
Yeah, we do that. And, you know, and I do a lot of microabrasion in my practice, and I do a lot of very conservative bonding. And so I am a great fan. You'll see in my little presentation, I believe in biomimetic dentistry. I believe in use of fibers. My last resort is putting a crown on that tooth. And so I've learned the hard way. So I'm hoping that maybe, just maybe, from some old dentist, you know, in Stratford, Connecticut, some younger guy goes, wait a second, maybe I'm not going to be so quick to put a crown on that tooth.
That's a very ethical way of practice, Dr. Hoos. I commend you, because a lot of times we're in the mouth, and not me personally, but that some dentists are, where they're looking for high dollar items versus putting the patient's interest above.
I have to tell you something very interesting. I don't know for the people around the world, but I have to tell you that we are under tremendous economic pressure where we are. And when someone comes in and breaks a tooth, and I don't know, in New York City, the fee could be $3,000 for a crown, and in New Delhi, it could be $50. I have no idea. But if I turn around and I say to a patient, you know, you should have a crown on your tooth, and they turn around and they say to me, I cannot afford a crown, my response is, and you'll see, my response is, I have something I can do for you for half of the fee that will work beautifully for many years. And let me see if and let's talk about how we're going to do that. Can you do that? And the answer is yes. How do we get these patients to say yes? Because it's wonderful to see people showing 10 implants in the maxilla and 10 implants in the mandible, or these amazing cases that are $100,000. I have to tell you that if you came home and your wife said to you, oh, by the way, I've decided that I'm going to be putting a new foyer floor in, and you say, okay, and oh, by the way, it's going to be $15,000. And you go, $15,000, really? And yet, you're very quick to say to somebody in your practice, oh, by the way, you need 15 crowns and they're $1,000 a piece. When do you want to start? We as dentists have lost our economic way. We sometimes forget how valuable money really is. And I'll tell you, there's a great book called The Sacred Cow. And The Sacred Cow is a very interesting book because it talks about the last sacred thing to talk about is money. People will tell you lots of things about their lives. They'll tell you the most intimate things. But if you say, oh, by the way, how much money do you make? They go, why would you say that to me? So it's the last sacred cow. So the interesting thing about money, I happen to be a watch guy. I like watches. If I go into a store and I see a Patek watch, I only have to make one decision. If what's in my pocket is worth less than the watch. So if you and I now are back in the 1800s and we decide we're going to barter for something, and you have a shotgun and I have 12 chickens, and I turn around and I say to you, I want to trade these 12 chickens with you for your shotgun. You have to decide, is my shotgun worth less to me than the 12 chickens? I have more than one shotgun. And if I get the 12 chickens, I can grow more chickens. I can harvest more chickens. For me, I have lots of chickens, but I don't have a shotgun. So we're able to make a trade.
Right.
When someone comes in your office and they need 10 anterior veneers, and you tell them they're $1,000 a piece or $50 a piece or whatever it is, they have to make one decision. Is the money in their pocket worth less to them than the veneers? It's a different way to think about money.
Yeah.
So when you present to someone a case, my case presentations are very short. Mrs. Smith, you need to have this. Have you decided in your mind how much money you think you'd like to spend on your dentistry? Well, I have no idea. So people make the great mistake. They take models, they take x-rays, they do full mouth wax-ups, they do all of these things, and they come back and they show the patient the articulator and they go, look how beautiful this is. Or they show them pictures of befores and afters. That's lovely. But if someone is making $1,000 a week and you turn around and you present a $60,000 treatment plan, you're an idiot. You're an idiot.
Yes, it's not going to happen.
Because you're competing with someone feeding their family, or you're competing with what I call the 2 V's, vacations and values. You know, so that's really, you know, my thought. So if I turn around and say to somebody, you need 30 crowns and it's going to be $45,000, and they look at you, what, have you lost your mind?
So let me ask you this. Back in school, they would emphasize that you are to treatment plan everybody with the same methodology. But when I went into clinical practice, it's very hard to judge. You know, I've had patients walk in with their overalls from the field, and and do like $40,000-$50,000 treatment plans and go up front and sign a check for it. And I've had people that looked like they're wealthy and they couldn't afford a crown. So it's very hard to judge what the income of the person is, and you shouldn't do that anyway.
Absolutely.
How do you come about making that determination that, hey, you have this discussion with the patient, you just ask them blatantly, hey, how much do you want to spend on your teeth?
So I'll tell you two quick stories, because that's how I sort of talk and lecture and teach, by storytelling.
Okay.
20 years ago, a guy came into my office who literally you could smell him from the parking lot. He came in and he said, "Doc, I want to do something about my lower teeth." And I usually, at that time, I wasn't wearing a mask when I was speaking to somebody like I'm doing now, but I had to put a mask on because I couldn't manage it. And I said to him, you know, your lower teeth are pretty much lost. You're going to need to replace your lower teeth with something that perhaps comes in and out of your mouth. He goes, I don't want that. So I said, okay, what does she want? He said, I want one of those things that you can't take out of your mouth. I said, well, to do that, it's going to be about $25,000. He goes, really? $25,000? Really? So what am I going to get for my money? $25,000. I said, you're going to get some implants and you're going to get something that connects to the top of the implants. He said, you mean a bar or do you mean individual teeth? And I'm saying, okay. I said, I'm talking about a bar. He said, are you talking about a bar that's porcelain fused to metal, or are you talking about something made from acrylic? I said, okay. He said, because I don't want any of that crappy acrylic stuff. I want porcelain fused to metal. And I said, okay. I said, if you want to continue this, we need to spend some time together so I can figure out your case. He goes, well, tell me something, Doc. Will you do any better for cash? And I go, no, I won't. No, I don't. He goes, okay. He said, I'm going to come back and see you, Doc. I go outside. I happen to walk him outside, and he has this huge, huge septic tank truck in my driveway. Now, a septic tank truck is something that sucks out septic tanks. Little do I know that he has about 50 of them. You cannot judge a book by a cover. You cannot. But you must ask open-ended questions about your dentistry. A second lesson. Lady comes in to see me, fur coat, the whole 9 yards. And she comes in for her hygiene visit. In my office, we do hygiene first. It's a controversial subject, but we do hygiene first in our office.
Good.
Because when someone calls up and says, I want my teeth cleaned, the answer is yes. We always work on the concept of yes. I want my teeth cleaned? Sure. The answer is yes. Can you cut off my arm and sew it to the top of my head? The answer is yes. But we have to talk about the ramifications of cutting your arm off and sewing it to the top of your head. Just as if someone comes in, I want all my teeth removed, what does that mean? Well, my father had dentures, my mother had dentures, I want dentures. Well, do you understand what that means? So I went in to examine her, and I recognized her immediately. And I said, welcome to my office. And she's a very famous person, and her mouth was pristine. And she said to me, aren't you going to say something to me about the spaces between my front teeth? I said, I wasn't going to. Is it of concern of yours? She goes, hell no. This smile has got me everything I have, quite frankly, and you're my dentist from now on. Because every GD dentist I go to talks to me about wanting to close the spaces in my front teeth. And I have zero interest in that. The point is, you must ask open-ended questions. So the first question that I ask a patient when they come into my office is, why have you come to my office?
You want to get the cheap complaint, right?
I so much want to talk, but the answer is, would you like to go to dinner with me? No. Oh, please, please, let me go to dinner with you. No. When the answer is no, what's the answer? The answer is no. So when someone comes into my office for extensive dentistry, they have to ask me 3 times. When they call on the phone, that's the first ask. Making the appointment, that's the first ask. The second ask is, why have you come to my office? And the third ask is, I want to do it. So if you decided that you were going to convert to a different religion, most people say you must ask 3 times to show your commitment to what you want to do. And every time that I've gotten myself into trouble in dentistry, it's because I was over anxious. I need to know that that patient is committed in terms of resources and time. Because there is something that's very interesting. The first day I got into dental school, the first day of dental school, our dean was a gentleman named Dr. Dean Shira. He was Dean Shira. He was a 4-star general from the U.S. Army, the only 4-star general who was a dentist. And he said, ladies and gentlemen, you are going to be given the right to cut human tissue. Think about what that means. And so I never pick up a scalpel blade ever without for 1 millisecond thinking that I have been given a right that only priests had to cut human tissue. It's very humbling. And so when you pick up a burr, a diamond burr, and you start cutting down teeth, we are the only profession that is in the business of amputation, other than, of course, surgeons. But we are very quick to cut things down. We're very quick to cut things off. And so before you do that, think for 1 moment, if this was your mother, before you start yanking out her front tooth or removing all those teeth and cutting down bone, you have to think for a moment, if you were the other person on the end. I treat a lot of dentists. I treat many, many, many dentists. They come to lectures, they see what I do. A lot of them are baby boomers. Their teeth need, they need restorations. And all you dentists make the worst patients in the world because you know too much. But what happens is they go, now you're not going to take too much tooth off, are you? You're not going to do this, you're not going to do that. I mean, think about when you have your own dentistry. So we want to make sure that we understand there's a human being attached to this. I think David Hornbrook said in a lecture maybe 35 or 40 years ago, these are not pieces of wood. These are people attached to their teeth. So that's what I think.
Excellent. You have a very unique way of presenting your point, and your points are right on. I appreciate that, but you're gonna make me think now every time I pick up that handpiece and the blade. So
that's okay. That's okay. Just for a millisecond.
Millisecond is fine. So you also, on top of all your clinical expertise, you also teach doctors and discuss a lot in your presentations on how we can solve the problems that we face that include not only balancing art and science, but the business side of dentistry. You and I both know that half the equation is the business acumen that you have and how you treat people in your office. They will, patients have different priorities, as you know, than we do. And we don't learn much about dental, about business in dental school. So where did that come from? What kind of an approach do you take with balancing those three hats? Art, science, and business.
It comes back to being hungry. It comes back to being hungry. It comes back to the great fear of failure. It's very Freudian, but it comes back to trying to understand. I'm laughing to myself. I'm laughing at myself because there are a lot of things swirling through my head.
It's not the same environment as when you were in school. We got kids coming out with, I should rather say colleagues coming out with $500,000 in debt. They want to get
Absolutely.
married.
Yeah.
I mean,
So that I will tell you, there are a few things I will share with you. My father had a very tiny grocery store. A grocery store, obviously, was like you walk in, there was a counter and there were shelves, and he had a rule. No one ever left the store without a sale. Meaning to say that even if someone came in the store to look around, they had to at least leave with buying an apple for a dime. So the answer is that in your practice, you may not get to do a full mouth reconstruction, but when someone comes into your door and sits down in your chair, they have given you permission to enter their mouth. And everyone will tell you that that is the most intimate part of your body. So before you enter someone's mouth, you must ask permission. May I look in your mouth? You must ask permission. Number two, if someone comes in with a broken left lower molar and they say to you, Dr. Hoos, can you just smooth that off for me? What's the answer?
yes.
Yes. Yes. I have never charged for a denture repair in my life. I have never charged for a denture repair in my life.
Hang on 1 second there. Are you doing them yourself at the office, or you send them out to the lab?
If I have to send them out to the lab, if I do them in the office, now I'm very fortunate I have a lab technician in my office. But even before, when I was doing them myself or sending them out, I never charged for a repair.
Regardless of how long it's been since you made it?
Even if someone else made it.
Really?
Now, think about it. So someone comes in with a broken denture, and it's broken in half. And it's Friday afternoon at 5 o'clock. And their daughter's getting married Saturday. You better know how to do that yourself. So if you don't know how to repair a denture, you better learn how to repair a denture. Number one. Number two, Mrs. Smith, I've taken care of repairing your denture. You really need to have some new what? Teeth. We don't make dentures in our office. We make teeth. We don't make plates. We don't make dentures. We make teeth. So when it comes time to have your new teeth, I'd like you to think of me. Bread upon the water. Bread upon the water.
That's a very nice thing to do on a Friday night at 5 o'clock. You probably get out like.
But here's the interesting thing. I'm going to go back to the story that I told you. The story about the guy that smelled. I just saw him after 22 years of never seeing him. He walked in and said, I'm ready to have my top teeth done. And I said to him, Arthur, where have you been? Who's been taking care of your mouth? He goes, Doc, I didn't need anyone to take care of my mouth. I clean my mouth like I'm supposed to. And quite frankly, when I looked in his mouth, there wasn't a bit of plaque anywhere, but his top teeth were worn out. And it was time. He goes, and Doc, let me ask you, is it going to cost me a little more than $25,000 now? And went out to the front desk and gave him a check for $35,000. The point is, it is not what you do for the patient, it is the relationship you make with your patient. So those people who are most successful in life do not appear to be anxious.
I see. That's actually very good. You're right. If you do something good for a patient, they rave and they rave about you, and it creates a lot of business. In business school, what they taught us was, care for the other person's needs first, and your needs will be taken care of.
That's exactly right. And if you and I just celebrated 45 years of wonderful marriage, and I will tell you, for those of you who have trouble in your relationships, if you think about the other person first before you think of yourself, you will win. When you So when you present a case to somebody and you know that they need 10 veneers because they have black line corridor disease, I call it, you want to build out the buckles so they look. Do not be such an arrogant guy to say, Mrs. Smith, let me show you what I can do for you. And you quickly do a mock-up in composite. And you give them the most important thing you have in your office called the MIRROR that you get at a store, and you have that on their lap so that they can see what you're doing, okay? And you do the mock-up and you say, Mrs. Smith, you need 10 veneers. And I don't know what your fees are where you are, but let's make up a number, $1,500. That's $15,000. Is that something you're ready to do? She goes, I would love to do that, but I can only, I thought maybe I could spend $10,000 or $12,000. Guess what? They're getting those other veneers for free. Why? Because that is going to be the billboard of your practice. Just as when you do your implant cases and you design them for 6 or you charge for 6, for me, only for me, if I can do 8 and I need to do 8, they're going to be charged for 6.
You're going to be charged for 6. That's great. Yeah, I do that a lot too, because a couple of $100 here and there.
Absolutely. Because no one ever leaves the store without a sale.
I have a policy like that too, Doc. And the policy in our office is if they are done and they're up for a 3-month or 6-month recall or whatever it is, at a minimum, ensure that they're on a schedule. Even if they don't have their schedule with them, just schedule something tentatively so they don't skip out of the system.
And no one ever leaves the office without an appointment.
That's right. That apple.
Okay.
Dr. Ouz, what a great discussion. I really enjoyed it. With that said, I'm actually going to probably contact you to pick your brain a little bit more. But for our audience, I'm going to go ahead and switch you over to the presentation.
Okay.
Where you will give us a little bit more detailed insight. And here it goes. The floor is yours.
So I want to thank everyone for coming. And this is the logo that I use for all of my lectures. It's a man balancing. And so when I talk about balancing, I really talk about balancing the art, science, and business of dentistry. So this concept of problem solving with composites, the truth of the matter is that in your practice, you must have a mission statement that you believe, your staff believes, and that is practiced every day. So if you don't have a mission statement, steal mine, because I probably stole it from somebody. The concept of providing the highest quality care to the most number of patients while maintaining a balance of art, science, and business of dentistry. Dentistry is like a 3-legged stool. You can do beautiful dentistry. It's got to be based on good science, good research. And in business, it's got to be repeatable and reliable. Carl Misch, may he rest in peace, said that if you do implants and you lose half of them, then you're not doing very good business. What you're doing has to be repeatable and reliable. If you're having post-operative sensitivity in your composites, you have to revisit what you're doing. You know, understanding that all clinical situations are not the same. That though everything might look like a pineapple, if you look closely, that person in the middle ain't no pineapple. The problem that we have in dentistry is that there are so many tools. Which one of these tools do we use? And I've asked this question myself 1,000 times. If the number one bonding agent in the world is made by Curare, Curare Protect Bond or SE Bond, then why are there so many bonding agents in the world? And if the best implant is X, why are there so many implants? Or the best composite, or the best this, the best that. So there are lots of tools to choose from. You just have to figure out when to use them. Because it's quite frankly, it's extremely difficult to see what's in front of you. It's sometimes hidden. And so you have to figure it out. And every guru needs a guru. And you're listening to me or you're listening to many other lecturers, we all have opinions. We just need to make sure that these opinions are based on what I call clinical success. I am a wet finger dentist. I work 165 days a year and put in 4 10-hour days. And I base my talks on what I've had success in my private practice. Now, I am president of the Giraffe Society, and the key to being part of the Giraffe Society, and all of you are part of the Giraffe Society, you have to be willing to stick your neck out. You have to be willing to try new things, but the key to it is you don't take a weekend implant course and then go in on Monday to do bilateral sinus lifts with, multiple implants. You have to build upon your knowledge so that you don't get your neck cut off. The interesting thing about dentistry is that in 1975, when Ray Bertolotti brought back the concept of dental bonding, he was told that the only people that are going to be happy about dental bonding with acid are the endodontists. So when you think about this, every new theory passes through 3 phases. First, it's attacked and declared absurd. You cannot put titanium rods in bone and have the bone adhere to the rods and therefore be able to build teeth. Then the theory is admitted that it's true and obvious, but it's insignificant. I mean, we don't need dental bonding. We have enamel bonding. And besides, we don't need bonding at all. We have pins that we put in teeth. And then what happens is that theory is recognized as being real important, and the detractors demand the honor to have discovered it. That we know that there are people and companies that said dental bonding wouldn't work and did everything they could to disparage it. And now some of those companies are the people actually producing bonding agents. So you have to try new things. But you have to understand that the fear that you have of trying new things is false evidence appearing to be real. Think about it for a minute. Your fear is based on false evidence appearing to be real. That 20 people can tell you to try a new restaurant, and one person tells you not to, you don't go. So in dentistry, when one person says it doesn't work, you tend to believe that. You have to be basing your facts on your own clinical experience and what other people are talking about. So clinical situations and problem solving and providing care is really what being a dentist is about. I love Captain Jack Sparrow. The problem is not the problem. The problem is your attitude about the problem. And you got to think differently. You have to think differently. You have to realize that balancing the art, science, and business of dentistry is understanding doing beautiful dentistry is one thing, but it has to be based on good science. And it has to be done in a clinical situation where, quite frankly, you can make money, provide for your family, and provide for your staff. So every day we get presented with these problems. So think for a moment, how would you handle this? How would you handle that broken tooth on the top left? How would you handle that fractured tooth on the top right? How would you handle the tooth on the bottom left? Take it out, put a crown lengthening, and more importantly, how would you handle this fracture for this patient that you think this tooth is condemned? And how would you handle this? How would you handle this broken tooth? Oh, I would put a crown on it. Oh, really? Okay. How would you handle this tooth that has no ferrule that's broken off of the gum line? And how would you handle the tooth with this amalgam in it that's sensitive to biting on? Would you put full coverage on it? Partial coverage? Do nothing? Reduce the occlusion? What would you do? So you have to be careful when you look at these cases, because sometimes you open it up and you get yourself into a kettle of fish or a bucket of worms or a can of worms and you go, why did I ever touch that tooth? It was only sort of sensitive, and now it's really sensitive. So you have to look closely and you have to think differently, because what you're looking at may not be a frog. It may be something else. So when we start talking about these things, we really have to think about what a teeth really like. And it's been shown that at the DEJ, there are actually fiber tufts that attach the enamel to the dentin. And that the structural development of a tooth in the early embryonic bell stage, collagen fibrils are acting as an interface. So Pascal Magnier said, how do you get two dissimilar materials, enamel and dentin, to act as one? And this is a slide that was given to me that shows the fibrils that are actually attaching the enamel to the dentin. And so if that's the case, then what are we doing in our lives, in our dental lives, to mimic biology or biomimetically treat these teeth? Like, what is the story with this biological dental fiber that's there? And what are we going to do in terms of composites and managing this? Managing the DEJ in a biomimetic manner. And how do we best use adhesive dentistry to do that? So I like a product very much called Dentapreg. And the reason I like Dentapreg, and there are other products out in the marketplace, but I like using fibers in dentistry. And Dentapreg is a company or a product that's manufactured in Czechoslovakia. A lot of people don't know about it, but it's fibers that has been coated with resin to work in synergy with each other. And what happens is that when the compression occurs on the composite, the tension is relieved through the fibers. So if you look at the lower left picture here, you see a swimming pool being built. They're using rods within the concrete to absorb the tension or absorb the compression so that the tension can be distributed through the concrete. That's what rebarb does. The rebarb is actually floating within the concrete. That's why we can build big buildings. So if this is presented to your office, how do you handle it? And what are you actually looking at? And how did it get that way? So I like to be clean and retentive. The device on the left is a device made by Crystalmark, which makes an amazing air abrasion unit that I have in my office. They are an amazingly precise instrument. They're not inexpensive, but they're not expensive when you can think about what you can do with them. But you can also use a sandblaster in the patient's mouth, being careful. It makes a mess. You want to use high volume suction. You want to use a rubber dam. You want to use isolation. And you want your preps to be clean and retentive. But I'll tell you something else. You can't treat what you can't see. And most everyone who's listening to this seminar, I am sure, is using loops. But I've found some loops that I really, really like, made by Oroscoptic. That is a zoom loop, and you can get 3x, 4x, and 5x. And so when I'm doing my hygiene exam, I'm using 3x. When I'm using my regular dentistry, I'm using 4x. When I'm doing more detailed clinical work, I use a 5x. But they've come out with a new light called True Color that is really amazing in terms of giving you the true color of what you're looking at. And I don't get anything from promoting this product. It's just something that I like, and I thought I'd share it with you. So here we are. We've created some retention on this tooth. We've cut back this tooth a little bit using a burr. And the reason we don't use any straight lines is because we want to hide the composite resin. We're air abrading this, getting a good surface. And notice how I've positioned, this is a Garrison mylar strip. And I have Teflon tape on the tooth to the left. And I have the patient biting in full occlusion with the positioning of my mylar strip. If you look very carefully, I have used flowable SE bond with flowable resin, and I have a piece of Dentapreg embedded in that flowable resin, right dead center. I happen to be what I call a cutter downer. I like building up my composite and then cutting it down into the shape. And they fold it over, and there I have it. And I use this happens to be a Comet, Komet finishing burr, where I do my bulk finishing, and I'm bringing it down. You can still see some of the aluminum oxide hanging around, polishing it back. And then what I use is a red pencil to create my mamelon effect, or you can use a regular pencil. And then I use a Comet bristle brush to get my final finish, and there you have it. Now, what's interesting about this, and someone may have detected this is actually a porcelain veneer repair. And yes, my porcelain veneers break, and so I may have to replace this porcelain veneer, but I'm using the art, science, and business of dentistry because I want to give that patient immediate satisfaction. And when you look down upon this, you can see, and this is a little bit of a trick, that when you want to know whether your crested contours are correct, use a large mirror and look down the long axis of this tooth. And you can see that this repair is basically virtually invisible. When you use your rubber cup or wheel, make sure you use copious amounts of water, because if you don't, you will change you'll actually change the chemical nature, or you'll heat up the composite, and you may get discoloring and or you may get a pullback from the margin. So you want to use lots and lots of water. And if you're having postoperative sensitivity in your composites, think about how you're polishing it. Put a rubber wheel on your finger and see how long you can keep it there without it burning your nail. And again, looking down the long axis of the teeth, making sure your contours are correct. There's also a little nuance here that I want you to notice, that on the distal aspect of the repair, notice that we've curved it in a reverse manner to have it appear to be more narrow, but at the same time, keeping our contact. That's just a little trick. So when you have a similar situation where this tooth is broken, we've removed the old composite in the center, air abraded, and notice the wedge on the top right. That's what a wedge should be doing. so that you can actually move the tooth, because you're getting a mechanical advantage. Again, I told you I'm a cutter downer, and so I'm overbuilding. There's dentapreg within that composite. I'm folding it over and I'm finishing it back, getting my final contours and shape and shine. And there's my final product. Now, the key to this whole thing is the refraction of the light. If you notice from the flash how the light is reflecting back to you with the same mamelon that's on the tooth beside it. You're doing that and if you do that, it will aesthetically look correct, and you won't get that dull look, or you won't get that dull feeling of the tooth. So here we have someone who's come in with a broken corner of his tooth, and the question you say to yourself, why did it get like that? Occlusion, 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 and more occlusion. And guess what? The problem is occlusion. So when we look at this, we want to check our anterior guidance, and by having a piece of articulating paper in there and having the patient go through their anterior left and right excursive movements, you'll have an understanding. And look at the lower right. Notice that the canine is behind the other canine. So it's interesting to see what's actually happening with this occlusion. So again, the same exact thing. Cleaning the tooth, air abrading, and notice how the dentapreg is positioned. It is positioned and bonded onto the tooth. So when we think about the enamel-dentin interface, what we're doing is we're mimicking nature using the dentapreg. Again, I'm a cutter downer, lots of water, getting ready to do everything, polishing it back, and there's our result. Now, what's the problem? The value's wrong. That'll stay there, but the value is wrong. It's not a good job. It's the contour's okay, but the shade is wrong. Or if we think about color of teeth, we know it's made up of three things: hue, chroma, and value. When looking at teeth, the most important thing to understand is not the chroma or the hue. The most important thing is to understand is the value. Generally, when your shade is wrong, it's because the value is wrong, which tells us that teeth really are made up of enamel and dentin, and how the light transmits back to your eyes is based on the glaze of the tooth and also the diffusion of the light. So we have to think about it in terms of restorative dentistry. So to go back, when we talk about dentapreg, these are fibers that are e-glass. They make multiple different configurations. And I will share with you, and I can't believe I'm saying this, but if you write down my email, jchdmd@gmail.com, jchdmd@gmail.com, I will send to you a dentapreg sample. And if somebody basically, I'm going to make up maybe $12 or $15 for a sample so that I don't have to eat the postage and stuff. I'll talk about more about this at the end, but maybe 12 or 15 bucks. I don't know how we're going to do that. I'll send you a sample of dentapreg that cost about 180 bucks. So we'll think about this. So when we look at this tooth here and we say to ourselves, what are we going to do with this? We're going to figure out a way to rebuild this tooth. We're going to isolate the tooth. We're going to treat the tooth with SC bond. We're going to place flowable composite. And we're going to use some dentapreg fiber to act as that dentin enamel interface. So in this particular case, I'm spreading it out. And again, I'm a cutter downer. I've rebuilt it up. And that's my restoration in occlusion that has reproduced the cusps. I've onlayed the cusps here, and there it is, an occlusion on the bottom. Now, if you notice, I mean, the occlusion's not ideal here, but this patient who came in, and I went back and you look at this tooth, this is basically with the amalgam, the cusp had broken off and the amalgam had, just needed to be removed. You know, I said to her, you know, you need a crown on this tooth with a crown buildup. I gave her the fee. She said, I can't afford that. So that's when I said to her, I have something that will cost half of that and will last a very long time. And when it comes time to do a crown, if it's necessary, I'll have the perfect base to be able to work with. I can promise you I'll never have to put a crown on this tooth. So here we have a clinical situation where this tooth is sensitive to bite on. Well, of course it is, right? How long has this amalgam been here? Well, it looks like, quite frankly, it was put in with someone's thumb, but it's been there a very long time. And it actually is probably the third restoration on this tooth. And you can see the distal crack. So what I did was I removed the amalgam. I isolated the tooth using Teflon tape. There is not a rubber dam here. I so apologize. I shoed the cusps. I rebuilt this tooth. You can actually almost see the dentapreg inside. Okay, this is a close-up of this tooth. And this tooth was no longer sensitive, and it was just restored in an ultra-conservative way. When you look at this tooth, you say to yourself, well, what happened to this tooth? What happened to this tooth was that the laws or the scientific principles in terms of rebuilding this tooth were not adhered to. That's what happened. So when we look at this tooth and we take off the part that's broken and we isolate it and we do all the different things we need to do, and we realize that we've got to rebuild this tooth biomimically, that we can do that and create a tooth that will last for years and years and years. So those of you who do post and cores, you understand that posts and cores are very detrimental to teeth, that they fracture teeth, and that the reason they fracture teeth is because the vector of force goes down the long axis of the tooth. The tooth is then what I call paper clipped to death, and the tooth fractures. So for me, the Walt Disney quote means a lot. It's kind of fun to do the impossible. You know, stuff that's easy, anyone can do. The impossible is a lot more fun. So when I think about dentapreg, I like using what's called pin posts. And I think about this in terms of pieces of plywood. Plywood works because it's multi-layer. And so having a post that's one piece makes no sense to me. Then when I look at a tooth and I see a post and core that comes out, I say to myself, this is a difficult clinical problem. That a lot of us know that this tooth should be taken out and perhaps do an implant. But again, think about yourself. You came into my office, you're a dentist. Gee, Jeff, can you save my tooth? Strength in numbers. Now, this is a very difficult clinical situation. We know that this tooth is really condemned in many ways. But if we remove all the decay, we create a reverse ferrule. We use multiple pin posts in this tooth. We're buying time. Now, it's not ideal, but we're buying time. And we rebuild that tooth in composite. We can buy this patient a lot of time. Again, similar clinical situation. And yes, I had to do some crown lengthening on this tooth, but that ferrule will work for a long time. Again, here we have a tooth that has a thermofill carrier broken off of the gum line, creating a reverse ferrule in a sense, using our pin post to build it up. Notice I've spread the pin posts out a bit, all right? And what I'm doing is I'm re-cementing that crown back, getting the composite or the bonding agent that we're using to spread out over the tooth. So now I've used Photocore in this tooth, a Curari product. I've used SE Bond to coat the fibers and SA Cement. All the same company using the same science of adhesion. And there's our tooth, there for a very long time. Now, sometimes we need to stabilize teeth. And we're going to go back to these same principles. I like these toothpicks very much. They're hard to get, and I like the fact that they pull back the lip for me. But more importantly, they put these teeth back into occlusion. That when you put your fingers on patients' teeth and you ask them to tap their teeth together, you want to feel what the fremitus feels like. You want to see what kind of movement you're getting. It's like having a picket fence. Sometimes teeth are revulsed. What we're going to do is we're going to put them back in position and create that picket fence through strength. And notice this fence is made with the X marks the spot, or should I say, getting mechanical advantage. Again, the Dentapreg PFU fibers give you a unidirectional fiber. So I cut a channel in these teeth because I need to save these teeth for a long time while I'm treating the mandible. These teeth will ultimately be lost. True or false? These teeth will ultimately be lost. True or false? I'm already creating my embrasure spaces. I'm created a clinical situation where my fibers are going to be intercoronally in the tooth. I'm going to look at my anterior guidance carefully. There I am. There's my Dentapreg. There's my flowable composite. I have lots of cleanup to do here, but I can do that. But you have to remember to check the occlusion. Check the occlusion. Check the occlusion. But for those of you that are using articulating paper, if you don't know about a T-scan, you need to know about it because articulating paper is usually wrong. Look carefully. The mesial spot on the canine is not even in occlusion. The tip of the lateral is not even in occlusion. The articulating paper is wrong. When you use articulating paper, you must put Vaseline on your articulating paper to get rid of the smudges. So here we have another clinical situation. This patient has broken their tooth. They can't afford crown and bridge. The tooth is mobile. Let's see what we can do for this patient. We're going to create a Dentapreg splint. That's what we're going to do. Because the answer is yes. Dr. Hoos, can you save my tooth? The answer is yes. So here we are. Now, is it the most beautiful restoration in the world? No, it's not. But I have to tell you that this has probably been in this patient's mouth for 15 years. And as I said in the beginning, most of the time, the only way a patient loses a tooth is we take it out. Again, using those toothpicks, creating a stent or a splint, those teeth are mobile, getting the fibers intercoronally into the tooth, explaining to the patient that you're going to be cutting a channel in their tooth. You always inform before you perform. May I please? If the answer is I don't want to do that, the answer is no, then the answer is no. You only have to say no once before the answer is okay. Again, this is a different situation where the stent or the splint is created in the anterior incisal edge, and you'll see why. Because I wanted to recreate their anterior guidance. I built their teeth up to recreate their anterior guidance. And I prepared a crown on the lower left-hand side on the canine because I'm going to be doing a unilateral semi-precision attachment here for this canine, and I'm going to be doing a full mouth recon for this patient, and I need to reestablish their anterior guidance. So long-term solutions are very important because many times the temps need to last. This temporary situation needed to last about 2 years. So keep calm and think long term. Short-term solution versus long-term solution. When we have a case that's failing, like these 2 front crowns, and we have a lateral that's failed, or a central that's failed, what I'm doing here is I've removed the central. What you're looking at is you're looking at cytoplast after the bone graft has been put in. The cytoplast, this tooth was taken out using osteotomes very carefully. Notice the gingiva was not broken. The area was degranulated. The bone graft placed. The cytoplast cut precisely, put underneath the tissue, and a cantilever was made. The cantilever was made using Dentipreg, measuring across so that I can use this as a long-term temporary before my bone graft is ready to be used for my implant. Okay? So it's a long-term temporary before my bone graft is ready to be done for the implant. Now, a lot of you are doing immediate placements, and that's all great. My rule is, and it's a discussion I've had with many people, my rule is if a tooth is endodontically treated and removed, the implant is not placed. That is an absolute rule. My statistic success in implants in the maxilla is about 92%. Of the 8% that I lost, half of those were from immediate placement on an endodontically treated tooth. Now, someone would say, well, that's still a very high percentage. The problem is when it happens on that patient, it's 100%. And when you have a failure and you have to regraft, it extends the treatment. So therefore, I have abandoned doing immediate placement on endodontically treated teeth. Now, we need to help people who can't afford treatment. We need to do that. So this is Heroodontics, using Dentipreg. I am using Dentipreg bonded to this tooth to rebuild this tooth like this using composite resin. I am now taking a clear crown former, rebuilding the tooth, cutting it down, reshaping it, polishing it for a final result. The real question is, how long will it last? Surprisingly, if you're willing to stick your neck out and think about problem solving, it'll last a very, very, very long time. Occlusion, occlusion, occlusion. Balancing the art, science, and business of dentistry. So we went through a lot of things very fast. I'm happy to answer any questions. And what's fun?
That was an amazing lecture. So there's a question about how do you find T-scan to be effective for assessing?
As I said in the sort of the lecture or the presentation, articulating paper is wrong. It's just wrong. If you're not using a leaf gauge, and I'm sure most of you know what a leaf gauge is. If you don't know what it is, look it up. If you don't have one in every operatory, then you need one in every operatory. I use a leaf gauge all day long, every day. The thing about T-scan is the wow factor is amazing, that the patient can see in real time what's happening in terms of their occlusion. But for me, I'm old school. I always verify my T-scan with my leaf gauge. I just have to. I just can't help it. So for me, using a leaf gauge Now, I will tell you, I don't have a T, I have 10 operatories. I don't have a T-scan in every operatory. And so it gets moved from room to room. But if I'm doing a clinical assessment, so as I said, I do a lot of TMD therapy. So when someone comes into my office for their initial consultation of a TMD, I will many times use a leaf gauge quickly to see what's going on, but I will always show the T-scan so the patient can actually see. So here's an interesting thing. I want everyone for 1 millisecond, I want everyone to slowly open their mouth, just open their mouth, put their tongue on the roof of their mouth, and slowly close. And every one of you, or most of you, have a prematurity, right? You have a prematurity in your mouth. Did you try it? Open your mouth slow, open your mouth a little bit, put your tongue on the roof of your mouth so your jaw goes back into centric relation, close slowly, and see where you first touch. Where is it?
Somewhere in the
Somewhere in the
posterior.
posterior. But you're not hitting all your teeth simultaneously, are you?
No.
No. Let me ask you something. You suffer from headaches?
Occasionally, yes.
But the interesting thing is, occasionally. So if someone said to you, I'm going to adjust your occlusion, I'm going to eliminate your headaches, you'd go, what are you talking about? Well, you have a prematurity, right? Because prematurities cause headaches, don't they?
Yes, this would be a lecture a lot of MDs would benefit from.
Exactly. So the answer is I do an occlusion lecture. But the truth of the matter is that if I have 300 people in a room and I ask them this question and 50% of them lower their hands, or excuse me, I say, how many of you have prematurities? Almost all of them have prematurities. So I say, of all of you, how many of you have headaches? Maybe 20% raise their hands. So what we've done is we've done a quick study that just shows that prematurities don't lead to headaches. Prematurities don't lead to malocclusion doesn't necessarily lead to headaches. It's not your teeth, it's what you do with them. Now, if you clench your teeth or you break things, so where do you most often see broken teeth? Lower second molars on the distals. On women especially. Why? Because at night the jaw falls back, they go into centric relation, they clamp down on it, and they glide forward. Therefore, when you see someone that has anterior wear on their front teeth and they go, oh, we have to increase the vertical. Wait a second, you don't need to increase the vertical. What you need to do is you need to find the prematurity that forces them forward. So it's very complex. That's why all patients that have TMD work in my office, they must go into a point-stop appliance for 2 weeks because all of them have muscle soreness.
But how do you restore the worn dentition that's down in the nose? I mean, you got to do something, right?
Yeah, so the answer is, well, you have to do something. So let's pretend for a moment that you live in Connecticut and you're a dentist and you have worn dentition. And you come into my office, you say, Jeff, I have worn dentition. I want you to restore my mouth. And all the dentists I treat, I say, look, guys, you pay full boat. I apologize, but I could have my whole office full of dentists having free dentistry. Now, you can pay for the lab work yourself, but if you want to be treated in my office, it costs money to do that. So if I turn around and say to you, you need 30 crowns and they're $1,700 a piece, you go, are you kidding? Well, you present those cases to patients all the time, right? You're not willing to restore your mouth. And the truth of the matter is, I'm finishing a dentist right now. It's a $45,000 case. The answer is that when you restore these cases, they have to be neutral in terms of their myofascial pain level. So they need to go into point-stop appliances. They need to have splint therapy first. Their vertical needs to be reestablished or determined in terms of their temporaries. And then these cases are always restored, upper anteriors, lower posteriors, upper posteriors, lower anteriors. Upper anteriors, aesthetics and phonetics, lower posteriors, vertical dimension, upper posteriors, maintaining vertical dimension, lower anteriors to tweak the anterior guidance.
Let me get this straight. Are you having them in temporaries the whole time, or how do you mitigate the spaces if you're just going by sectants or quadrants?
So what's happening is that makes the case very difficult. So I establish these cases and I rebuild them in composite.
Oh, okay.
There is an amazing dentist. His name is Gerald Benjamin. He's a very good friend of mine who I've never met. But he and I have had multiple conversations. He and I both do it the same way. In my occlusion lecture, what I show cases, one particularly of a dentist, I rebuilt everything in composite first. Now, sometimes you can't do that. You have to use long-term temporaries that are heat processed. But the biggest mistake that people make, for me, and I'm going to preempt this, there are dentists that are much better than I am, that have golden gifted hands that can do things that are just amazing.
There's always someone better, Doc.
Right. But for me, I cannot cut down 30 teeth and figure out how to do that case. I just can't do it and be confident. Now, I would be lying to say that I haven't done it. I'd be lying to say that I haven't done dual arches. I'd be lying to say, but I will say the following. There's no mistake in dentistry that I have not made. Not one. There is one. I have never taken out the wrong tooth.
Really?
I have referred the patient to take the wrong tooth out, but I personally have never taken the wrong tooth out.
I guess you check the x-ray, check the tooth, check the x-ray, check the tooth.
Yeah. But I've never done it. I've never taken out the wrong tooth. But what I would tell you is, you must know where, there's a book by a guy named Stephen Covey, The 7 Habits of Highly Effective People. You must know where you're going before you're going to get there.
Yeah. I do a lot of surgery, like tens of thousands of extractions over the years. And there was one case, but you learn and get better, but it was reimplanted right away and worked out just fine. But it does happen to us if if our mind and you're not completely there with the patient. It can't happen.
Right.
It can't happen.
You have to, when you find yourself rushing, stop.
Yeah.
Stop, stand up, go check a hygiene patient. Or if you find that you can't fit the screw in the implant, stop, get up, come back and put the screw in. The amazing thing about dentistry, America's pastime is baseball. If you got up and you hit the ball 50% of the time, you could play for any team in the world. If you shot the basketball 50% of the time, you could play for any team in the world. If you hit the wicket 50% of the time, you could play for any team in the world. If you scored a goal 50% of the time playing soccer. But in dentistry, if you're only 50% successful, you're either out of dentistry or in jail.
Yeah, you can be. There's not much room for mistakes. And also,
absolutely not.
You end up taking the wrong tooth out. You have to follow certain protocols, make sure you reimplant right away, you do the endo later and all of that. It's a very unfortunate situation. Wow, Dr. Hoos, what a presentation today. Maybe I'll take one more question. The last case that you were doing, how did you manage the centric and the eccentric contacts?
I didn't even remember the last case I did. So when he asks how you manage the centric and eccentric contacts, the word eccentric I'm not familiar with. I don't know what that means.
I presume it's talking about unusual patterns on your occlusion, lateral movements, things like that.
So when you adjust occlusion, you must use a leaf gauge. You must use a leaf gauge because you have to decide what is the difference between centric relation, centric occlusion, and habitual. When you tap your teeth together, that's habitual. When you put your tongue on the roof of your mouth and you close, you're back in centric relation. Centric relation and centric occlusion never is the same. So, oh, thank you. So eccentric movements. So when you take your articulating paper, cover with Vaseline, and you put it on the right side, you have your patient slide to the opposite side because you want to eliminate your prematurities on your non-working side. So you have to remember bull, buccal upper, lingual lower. You reduce the buccal of the upper and the lingual of the lower. The bull. And that's how you do that. Also, ask your patient when they're not numb, of course, when you tap your teeth together, what does it feel like? And if they tell you that they're still hitting hard on one side, believe them because they have the best articulator in the world. They have a brain. And remember that the periodontal ligament does not go through a ganglion. And that's why teeth are so incredibly sensitive. That your teeth are much more sensitive. That's why years ago when people graded pearls, they literally put them in their teeth and ran them across their teeth because your teeth are so incredibly sensitive. You know, it's very funny. Here's a trick question. When do your teeth touch? When do your teeth touch?
A couple of thousand times a day.
When do your teeth touch? When? When do they touch?
You jaw together. When you bring your mandible together with maxilla.
When your teeth only touch when you clench your teeth.
Right.
Your teeth don't touch when you speak. Your teeth don't touch when you chew. Now, you could say, I incise something. The truth of the matter is your teeth don't touch when you chew. Because when they do, you go, oh, you scrape. Teeth do not touch when they chew. What happens is teeth only touch through parafunctional habits. Okay. Some people say teeth touch when you swallow. Swallow, do your teeth touch?
No, no.
No, neither do mine. That's why when you ask a patient, when you do your TMD assessment, and you ask them to count 1 to 10, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, and you watch their mandible move, they move side to side, it tells you immediately whether they have prematurities.
That's cool.
Anyway, you've had enough of me?
No, I could do this all day long with you, and I love talking to the older generation because they've seen.
Wait a second.
Well, let's put it the more experienced generation that passes on knowledge because you guys been through it all, and experience trumps all. You know, we practice and learn tricks and get better at it every year.
Remember, and I also want to remind people that if you want a sample of Dentapreg, send me an email and I will try to work that out.
Let me go ahead and put your email on the side here. Doc, bettersmile.com is where you can find Dr. Hoos. I wonder how long you've had that URL. That's a very nice URL.
I've had that URL for like 25 years since the beginning. But you want to send me via email to jchdmd@gmail.com.
All right. I'll get that put up on the site as well.
I want to thank you so much for having me.
You're very welcome. Have a nice day, and please don't hesitate to come back on the show here, hopefully next year, to give us some updates. What are you going for, 60 years of dentistry?
No, my decision is that I'm going to be done at 75, so I'm 68. But I will tell you what an amazing thing has happened. We've just been chosen to be a Nobel Teaching Center. And so we're going to be doing Nobel courses at our office, teaching, quite frankly, general dentists to get involved in implantology. Curari has agreed to also we're going to be doing lectures at our office, hands-on for Curari and Dentapreg. So we know there's social distancing, so we have the ability to do it for 10 people. The unique part about the implant course is going to be that we're going to be doing didactic models, hands-on, but then the dentists are going to be with me in my surgeries, and people that are local in the Connecticut area, I'm going to be spending a day with them in their office, and or they're going to be able to bring a patient to my office. So we're doing a little bit of a different approach. Listen, there are some amazing people. Arun Gar is out there. Picos is out there. There are people in lots of different countries doing amazing lectures. What I'm trying to do is I'm trying to do it with a little different approach, smaller groups, lots of hands-on, learning how to take out teeth properly, minimally invasive. Also, we've instituted XNAV in our office. Are you familiar with XNAV? Guided surgery?
Yeah, that's a very cool system. You get to have a direct visibility in a computer as you do it.
It's amazing. It's absolutely amazing. So love to come back sometime.
We'd love to have you, Dr.
I have one more pitch. Sending people out to Dental Insights.
Dental Insights, okay. I will get that information also to this group on the site here. Dental Insights, what do you want to tell us about that?
Well, so we started a Facebook group called Dental Insights that I'm the moderator for. It's specifically to share clinical cases, problem solving, having people share, asking questions, trying to help each other out. I will tell you, I was given a great gift in the beginning of my career. There was a dentist named Dr. Earl Slusky, who was an oral surgeon, who said, come to my office and learn from me. He taught me how to do apicos. He taught me how to do flaps. He taught me how to do so many different things. And so what I will tell you is that your job as being part of the Giraffe Society is being willing to share your information. It's not what I can do, it's what you can learn to do. Because if I can do it, believe me, anyone can.
You seem to be working with a lot of oral surgeons. That's great. So Jeff, why are you more on the restorative side, or are you doing a lot of surgery too? I see you doing everything on your website.
I do. I've placed lots and lots of implants. The only thing that I produce is the only thing I don't do is orthodontics.
Oh, you don't do the easiest, like the clear, correct, and
no. My partner does the orthodontics, and she's amazing. And so, and I don't treat many kids anymore. So I do mostly comprehensive dentistry, interesting restorative dentistry, full mouth recon, implant stuff. That's what Arun Garg, G-A-G-R-A-G. He does hands-on courses in the Dominican Republic. But again, a lot of things have changed through the social distancing.
Yeah.
So that's why we're doing
stuff now with all of the associations going online. I saw 4 of them yesterday: Greater New York, Hinman, a couple of the others. They're all going
New York cancel?
Yeah.
Yesterday.
And I saw the news yesterday. I don't know when they put the press.
I had 6 lectures scheduled around the country, and all of them were canceled.
Yep. You can expect a lot of whoever started at the beginning of COVID to get more active online is going to have the most amount of exposure to our colleagues, because most of us are, starting to slowly go back, but to get continuing education, it's a virtual matter now.
So one of the things we're gonna do in my office is so Curari has agreed. I'm speaking a little bit out of turn, but it's just you and I talking. Curari has agreed that we're going to do a seminar in my office that's going to be hands-on, that the materials will be sent to the participants so that they can follow me in my presentation by camera. So do you understand what we're doing?
That's smart, yeah, live surgical.
Right. So live composite. So that there is a device, an overhead scanner, an overhead projector that will watch me while I'm working, and you will have in your office the same models, the same materials, and you'll be able to follow along.
That's right.
So,
very smart. There's a lot of ways of doing it now. I really encourage our colleagues to also, it's a new era now. Things are a little different. The people that innovate and are smart about it are going to do a little better than the others.
So great speaking with you, and congratulations on everything you're doing. I think that it is really sticking your neck out, baby.
Yeah, it's part of our duty to the profession to do what we can. We all have core competencies and talents. Our particular mission is doctor to doctor, a new decentralized peer-to-peer operation. We only benefit from those talents of our colleagues and empower another. It's very neat. It's an academic, administrative, and a financial approach to the failing healthcare system worldwide, and it's gaining tremendous global esteem as we are expanding all of our regions, chairs, ambassadors, boards between the Global Implantology Institute, as well as the American Academy of Oral Surgery, as well as the Global Summits Institute. Those three organizations are working quite well in harmony, and there's over 70 doctors and specialists that are in the leadership of that. And we started it very recently with the Global Interdisciplinary Summit and the Global Implantology Summit before that, and the Global Executive Summit before that. And Dr. Hoos, you can expect an invitation from me to join us and bring us a little bit more of your wonderful knowledge so we can all benefit from it.
Thank you so much.
Thank you, and I wish you a great Saturday, Doc. And don't hesitate to call me. Anyone, you can email Doc on the email address provided, as well as visit his website. As you can tell from the hour-and-a-half discussion we have now had, Doc is very apt to help you. All you have to do is reach out. Thank you so much, Dr. Lewis.
Thank you.
Have a nice.
Bye-bye now.
Take care.